If you're a fan of the workshop or if you read the book, there's a part in there that talks about the 5 F's of physician engagement. And those 5s are feedback, fair, fun, fit, and fulfillment. And so one of those 5 F's we wanted to focus on today. And Hedi, I'm going to let you introduce our guest, Dr. Winnie Lau, because you introduce people so much better than I do.
All right. Well, I'm excited that Dr. Winnie Lau made the time for us today. She is an assistant clinical professor of neurology at UNC Chapel Hill, right? This is North Carolina, University of North Carolina in Chapel Hill. And so her expertise is neurology and intensive care, neurologist intensivist. So we look forward to really kind of getting a little bit more insights from you, Dr. Lau, today on how physicians find fulfillment. Dr. Wilkins was kind of the one who really birthed the idea of the 5 F's when I first reached out to him to ask him about how do we best get physicians engaged and keep them engaged. As you know, over time, I prefer to use the word partner with physicians, but we still call it the 5 F's of physician engagement. And so one of those F's is about fulfillment. So I'll just kind of let Dr. Wilkins kick off the questions.
You know, it's interesting in our profession, we run all the time. And other people look at us and say, you're just crazy. Why do you do this? And one of my thoughts was, well, it's fulfilling work. What can you say about that? I mean, is that something that resonates with you?
Yeah, I mean, I think the only way to really have energy to run and go all the time is to really, keep your eye on the ball, right? Why are you doing what you're doing? You're doing it for the patients because there's meaning there for you. And whatever that meaning is, for some people, their meaning is, education. For some people, their meaning is the patient care. For others, it's science and making advancement. But for me personally, in order to go, I particularly know, especially when I'm in the intensive care unit, because that is a 24/7 go situation. For me, I know that that person needs my help. That person's family needs my help. There's something that I'm uniquely able to provide for these people. And it's not always medical. And that's what really keeps me going, especially through those tough ends when I've been working an exorbitant number of hours to really get the next hour.
Yeah, and all too often, physicians are working just exorbitant number of hours, and not just physicians, but nurses and other high intense professions. And you mentioned something about the fact that they need your help. Why is that such a compelling reason? I often said to Hedi in our workshops, asking a physician for help is like kryptonite. You can barely turn that down. Why is that so compelling?
I think it's that many people, when they find themselves in the hospital, it's almost as if you're in a foreign country, right? And it's a place that I basically live in. And part of my job is to get that person readily comfortable in this foreign country that they're in, because we might be here for a while. And that I need you to be thinking about things pretty logically and thinking about the values that are really important to you, right? Because we're not going to make decisions out of the context of your values.
Yeah. Interesting. Well, now I've done a little bit of homework on you. I mean, you're humble in terms of what you do, but I know that at your institution, you're involved with things such as complexities in brain death testing, things like communicating practices in delivering serious illness communication and uncertainty, advanced care planning and palliative care, and then resident education and diversity, equity, inclusion. So that's a pretty broad range of interests. And I know you said that personally for you, these things were fulfilling, but what can you say about these professional pursuits that gives you a sense of fulfillment?
Yeah, with the exception of complexities in brain death testing, you could probably notice that a lot of those are just related to communication and education. Which to take from Heidi's own words of sometimes these are considered the soft skills, but I don't really think of them as soft. They're just not taught algorithmically, and they're taught with practice. I think the thing that those all actually really have in common is actually moral distress, right? If you think about it, they're all pretty tough topics, and they're all topics that really tackle things that could make us feel very uncomfortable, right?
Yeah, that sounds pretty challenging.
And I think sometimes it's very easy to forget that physicians have moral distress and that we're tackling with that often. We go through medical school and we're learning all these facts and these algorithms, but oftentimes we're battling an internal moral distress and we're not often taught to talk about it either.
Why do you think that people don't realize that physicians as humans go through that just like they will? Why do you think there's that lack of recognition? Because I agree with you that oftentimes people don't see that we as physicians can deal with that moral distress as well.
I think it's because there's, I guess there's a little veil that's put around medicine, right? Oh, you went to school for 10, 13 years to do this. That must have been hard. And we kind of make it this big lump of, wow, you've been doing this for 13 years. And so it's almost kind of like a mystery of what that looks like for us. And maybe we've kept it intentionally a little bit of a mystery. And I think to a certain degree, people sometimes feel like they can't communicate with physicians in the same way because of how much training and how much schooling and all of that. But, in fact, we're all just people, just like all other people. And we have our internal struggles as well. And I think I like to bring that back into medicine, particularly with residents and who I'm teaching and who I'm interacting with, is really bringing conversations back to the forefront. It helps me kind of work through my own moral distress, but I think it helps others too, because if we're just always keeping up a wall, that's going to make it really hard to find meaning if you're not really tackling something that's really bothering you.
Yeah, so you bring up something that Hedi and I have been talking about. I think it's one of the reasons actually that we came up with this workshop, is that particularly since this is mainly OPO folks that are on the phone, but certainly it appeals to everyone. But you talked about this veil that we put up, and sometimes maybe it's intentional, right? Because of how we've had to put up with things. And so I'm going to pose a big question to you. You work with residents, you work with nurses. How can non-physicians like OPO staff, nurses, administrators, how can they help physicians experience a sense of fulfillment? Because oftentimes, it's interesting that you mentioned this moral distress. A lot of physicians, including myself, we don't like the term burnout because that sort of implies that we can't handle things, right? And so moral injury is a more appropriate, at least that I feel, to say that there's a moral injury, that we're not doing what we've trained to do. And so we've posited that having a sense of fulfillment can kind of combat that moral distress. How can OPO staff or physicians or lay people, spouses, friends, how can they help physicians find that sense of fulfillment that you're talking about?
Yeah, I think that helping the physician sometimes we don't always recognize that the moral distress is what's making us anxious or burning us out. And I think I've even heard Hedi say this before, or it might have been you, just asking me if they can help me with something, or or acknowledging the bond that I've developed with a family member. You know, if I seem upset or distressed or even on guard, it might be because I'm still upset and reeling from a discussion that I had. So to really check in and say, like, hey, I heard you just finished that family meeting. It seemed like it was pretty long. Like, how are things? How are you? Is there anything I can help with? Is this a good time to talk now, or do you want me to come back later? That's acknowledging that I have a process that I need to get through as well.
That's really interesting. I think that some people are fairly reluctant to interact with a physician if they're not a physician themselves. I think they're fairly reluctant to do that. And again, I think it speaks to that veil. You were about to say something, Hedi, and jump in.
Yeah, I think exactly what you were saying, Dr. Wilkins. I think to your point, Dr. Lau, early on about that there's a certain facade or veil that's developed to try and protect, like a self-protective veil, right, from that moral distress. It can lead to a non-physician feeling like either the person is unapproachable, or it creates almost an intimidation type of barrier where we might think, oh, I don't want to bother them, or they might be uncomfortable if I ask them. But what I'm hearing you say is just try, you know, to at least acknowledge, wow, this looks like it must have been hard. How are you doing? You know, do you need a little bit of space?
Yeah.
Or, you know, would you like to talk about it, or just a simple, how are you doing?
And I think to kind of think about like the topic of the talk, right? Fulfillment, and how can an OPO help me achieve some fulfillment? Ultimately, I think everyone truly does want to advocate and support organ donation, right? Because even if you just look at it purely logically, which I don't think we should encourage that, but look at how much good can be done. And for physicians who come into practice, most of them presumably for altruistic reasons, would absolutely support that. But sometimes we're not in the mindset yet, because right now I'm still focused on the grief of my family. And you hear that me call them my family. I get very possessive, right? Like, you know, that's my patient's family, and I'm part of this moment right now. And it takes a little bit to shift my mental state over from caring for them, which will always be there, but to shift it away from protecting them into, okay, how can we give this closure, this resolve? How can we help others and turn this positive? But I have to make that turn as well. And I can say that, you know, there's never been a time where I haven't gotten the letter and felt that warmth.
You talk about the outcome letter of what happened.
Yeah, the outcome letter, and feel that warmth. And even I would say sometimes when it doesn't turn in that direction, or a family opts not to donate, a couple days later, I'm usually sitting there and thinking, oh, you know, I wish it would have gone that way. Unfortunately, it didn't. And so I think we all kind of get there. Sometimes it takes a little bit more time. And it doesn't have to be an excessive amount of time, but just a little breathing space.
I'm curious, Dr. Lau, I'm really curious. When you get that outcome letter, what do you do with it? I'm curious.
So, I mean, I read it top to bottom. I definitely read about the persons who have received, and oftentimes it talks about, you know, whether they have children or what their occupation is. I will often send it to the resident that was involved in the case with me. If I can remember, because they come so late. They come so late for, you know, appropriate reasons. So I will always try to send it to the resident that was involved, or if I had a nurse practitioner or a nurse that I knew was very closely bonded with the family, I will often send that along as well.
Just humor me a little bit. Why do you take that extra step?
No, I've never received one of those as a resident. And it wasn't until I became a critical care physician until my fellowship training as a critical care physician, that I got those first letters. And for me, it really was a big closing point for my interaction with that patient.
I think I just had a big aha moment, because now that I think back on my residency and fellowship, I don't think I received one either. It wasn't until I was an attending. And in my career, I didn't really interact with resident physicians a lot. But Hedi, I just had a big aha. Imagine the residents getting these letters, because they're transient. They're on service and then they're off service.
Mm-hmm. And you'll remember too that it's not just as a resident, when you're in training, it's hard to get closure on any patient, right? Even if they pass away, or if they start transitioning their care elsewhere, often it's the attending physician that knows that patient, or they just up and leave the hospital and you have no idea what happens to them. But here's this paper that even though this person has passed, you have this real sense of closure, and that something really positive has happened, even though that might have been a very painful situation for that family or that resident. Sometimes there's even a lot of guilt feeling, right? Was there more I could do? Was there something that, was there a better way I could have supported this family? And sometimes it's hard to get past those feelings as well. I can tell you that one of these sort of cherished items I have, I think some physicians will do this, kind of keep little mementos throughout your career, that when you kind of physically hold them and touch them, that they help you realign you towards your meaning, your fulfillment. Sometimes when you find yourself in that state of, moral injury and burnout, and you need some realignment. And I have one of these things, and actually it is related to organ donation. It's not a letter. It is a card. I don't have it with me. It's at my hospital office, but it's a very beautiful velvet covered card. And it's from a family of someone who was ultimately an organ donor. And it was a very tough case, because there was a medical examiner involved, an autopsy was desired. This could have been a heart lung, but there were just many things that the family needed emotionally for their closure. And fortunately, I wasn't so intimately involved in the case that I could actually sit down with family, and there wasn't a lot of conflict of interest for me. But I sat down, we talked through what they needed emotionally, everything that this young man could provide, and had been a first person authorization. And they ultimately were able to do abdominal. And I got this card from the family the day they left the hospital after the OR. And it says in there, this was the toughest and most horrible time in our lives, to lose our son. And thank you for what you did, because you made it just a little bit bearable. And that meant everything to us. And so I actually have this card, and I maybe hold it in my hand once every couple of years. And it really means a lot.
That gave me goosebumps.
Yeah, me too. I could tell. You can tell as you're recounting that story, and you said every couple of years. I'm curious, how long ago was that?
It was probably about 6 years ago now.
So that's really amazing to me, because, Hedi, I know we're talking about fulfillment, but you can see how it bleeds over into feedback, right? So that feedback that you got from that family really kind of fed into your fulfillment. And then years and years and years later, it's still helping you out. It's amazing to me. And, Dr. Lau, we hear this over and over again from physicians. And one of the reasons Hedi and I like to have these types of conversations is that nobody can tell the story like somebody who's actually doing it. So thank you for telling that story.
You're welcome.
I did want to pick up on two things that you said. I loved how you pointed out the my patient, how you snuck that in there and then you pointed it out, because that's something that I think we've been really trying to hone in on a lot in the training of how important those outcome letters are, but also how much you have really adopted this family into your own emotional process, and how super valuable it could be, just by that example you gave us, is if we close the loop immediately after the case was done. If we called you, for example, said, Dr. Lau, thank you so much for your help again last night. I want you to know we just spoke to the Smith family. They're so grateful again for everything that you did. They're so grateful to be able to donate. We're going to continue to follow the family. And just kind of that immediate feedback to you in terms of not making it about the other people that we're saving, but right now about this family, and letting you know that we're going to continue to care for them, that they're not just being forgotten about. Do you think that could be something that would that be welcomed?
I think so. I don't think anyone would turn that down. I would even add just a little tidbit going back to the residents, even saying, either asking, is there anyone else that you would want the letter sent to?
Yeah.
That was involved in this patient's care.
And that was the second piece I was going to pick up on, is I love that you pointed out the residents, because I think there is an element of, residents come and go, right? And so it, just like you said, sometimes it's hard to keep up with who was it again 6 weeks ago? And I think from an OPO perspective, it's easier to remember the attendings who are there consistently versus the residents who are coming and going. But I think having that opportunity to put that extra effort in, especially if we immediately connect with them at the time and say, I know you've poured a lot into this family. Would you like me to keep you updated on how things are going after the fact, how the family's after the fact, and also where we were able to transplant the organs, and include them in that outcome letter. I think that's a great suggestion, and something that hopefully folks who have joined us today will pick up on. Now I have a question from somebody. This is from Jessica. She says, do you feel that more prompt follow-up after a case would be more beneficial as far as closure for physician staff? We try to follow up very soon after case, often verbal in person at first in the hospital, so that we can try to catch the whole team for follow-up. I'm curious as to the timing of the follow-up with the outcomes and its impact.
I think it will depend on what kind of hospital you're at. I work at an academic institution where, although I work a lot, in any given ICU, I might be there only 1 out of 4 weeks, and then I'm at other ICUs. So it might be hard to catch me in person. So I think as the patient heads to the OR, has head to the OR, usually you can still find that physician who's on service, and then ask them, right? Let them know, oh, this patient went to the OR. Thank you for all your help. The family is very appreciative. And then asking what they would like for a follow-up, if they would want that, and how. At a private hospital, you might have, more of a core set of physicians. So it might be easier to tap into them in person and the team in person. But again, I think that close follow-up as someone is either heading to the OR or has already gone to the OR, and just checking in with that team and saying, hey, what kind of follow-up would you like on this? I think that could be very helpful.
Great.
I like the fact that you point out to ask them how they would like to be followed up with, because, some physicians, like you said, they're rotating off, they're 1 in 5, 1 in 6 weeks, the residents are mainly doing things, and other physicians, like you said, they really want to know. So instead of assuming, just ask thank you very much. How would you like us to follow up? I think that's a really great tip.
Yeah, and I know I kind of said I love that you brought up the residents, also for the very reason you mentioned earlier on that moral distress. It must be really hard when you're a resident going through training, trying to process that moral distress, but kind of almost being trained not to. My impression is, okay, correct me if I'm wrong, my impression is that there isn't really an outlet or an avenue for residents to work through that with somebody. Is there?
This is one of the reasons why, I don't know if I should mention this certain TV show on recorded air, but there's a certain TV show that's been running for many, many seasons that my wife and daughter love to watch. And it's a TV show about physicians. And oftentimes something bad will happen. And next thing you know, there's 6 or 7 residents sitting around at somebody's house, having a glass of wine, debriefing it and talking about it. And that just doesn't happen. I think that we really don't debrief these oftentimes painful experiences, or we may deflect it. How are you doing? Oh, well, just another day in paradise, and so I don't think it's debriefed as well. And so I think my big aha out of this conversation is to track down that resident physician, because they are still in training, and they are looking to the attendings to see how they process that. I think that's a fantastic idea.
Yeah, I think it's variable. I think it's culturally, we're attempting to change that in medicine and really open that up. You can tell that a lot of what I'm doing is trying and attempting to open that up and getting my residents to tap into that human element that initially brought them to medicine. And to be vulnerable, right? Especially by personally being vulnerable. But I think for the large part, especially OPOs should assume that doesn't happen. That's very specific to the current training time and even specialty specific. I think Dr. Wilkins in surgery, there's a very particular culture in surgery.
That's right.
And that's attempting to change too. So I would assume that the residents haven't had any opportunity to debrief. And we're not often getting checked in on, hey, how are you doing? We're becoming more aware of it and looking at it. And I think there are some places that are doing really great jobs with programs that look at not wellness, just mindfulness wellness, but counseling, right? Where does a physician go when a physician is in distress and recognizes it? Where do they go when they don't recognize it? Who's going to advocate for this person? But that's not universal by any means.
Yeah. Well, I would like to jump in and thank you personally for the work that you're doing towards that, because I think, you obviously are over residents and fellows and these physicians training, and, your impact on them is, I'm sure it's appreciated. So I personally appreciate you doing it, because the culture does need to change.
Yeah, definitely. And that's, I think, often something we hear from participants in workshops saying, well, when is that going to change? But like you said, the efforts are there. We're not there yet. Some places it might be better than other places, but maybe there is an opportunity for us as non-physicians to keep that in mind. I just think about the huge impact my first donor case that I experienced as an ICU nurse. I can only imagine when you have that added responsibility as a physician. So now you, as a resident, are experiencing that. You have that strong sense of responsibility for the outcome of the patient. And like you described, you're probably questioning yourself at this point, wondering, is there anything I should have done differently here? Did I provide the best care possible? And how's the family doing? And now you're dealing with that, and now you're already on 30 hours of working, and you're being dragged into the next big trauma, and you don't have time to deal with all of that, and you don't have somebody who knows the process well to debrief you, to just recognize that if we take that moment to acknowledge to a resident who's working with a patient that has the potential to be a donor to say, I realize these are not common cases that you will come across. This is actually pretty rare to be part of a donation case. And I realize that these are really tough cases emotionally. So I want you to know it's completely okay if you are feeling uncomfortable in any way, and if there's anything that you would like to debrief or have any questions about with the process or how the family is doing. And in what ways we can really use your help to make sure this family feels like it has the best outcome possible. Maybe if we just kind of, do you think it would help if we just acknowledged it in that way and just kind of, in a sense, put the cards on the table with the residents? Do you think that?
I think it would. It's tough. It's tough with residents, right? Because they are the busiest of the busy in the hospital, and they have a laundry checklist of things that they're trying to get done. And sometimes they're laser focused, and it can take a little bit to break that barrier for a second. But I think the way I would recommend doing that is saying, when you're asking a resident for something, say, oh, hey, have you ever done an organ donation case before? Particularly if you're asking them to come do the DCD declaration, right? Because I guarantee you, they have no idea what they're supposed to do when they go into that OR. So start with, hey, have you done one of these before? Is there anything I can answer for you? Like, if you haven't done one, I know it can be kind of complicated. Do you want me to walk you through anything? They'll absolutely appreciate that help. The less people that they have to go to for help, the better. So they'll absolutely appreciate that. And then afterwards saying, is there anything else you want to know about this case? Or do you want any follow-up from this case? And I think they will appreciate that, because it is a little black box that they're entering for a very transient amount of time. But there's definitely a learning opportunity there for them. So I would offer that, yeah.
That's great insight. So we heard that really the outcome of what happened with the family, how the family's doing, and then secondly, what happened to the organs are extremely helpful in providing a sense of fulfillment on donation cases. And then outside of a donation case, just in general, when we're talking about process improvement, in what ways can a physician find a sense of fulfillment? Does the accomplishment of an improvement bring that sense of fulfillment, or a physician being able to contribute to improvements of a process? Does that bring a sense of fulfillment?
Yeah, I think so. It really depends on what the physician kind of identifies as important to them. Quality improvement is everywhere, and you sort of have to identify with a certain mission in a certain way. I get a lot of fulfillment out of, watching my residents grow and watching them hold a successful family meeting and really be able to do that in a way that makes them bond with the family. I also get a lot of fulfillment actually when patients don't go to donation and they end up going to a hospice service because they're ineligible or they opted not to. I get a lot of fulfillment that they chose a route where the patient's comfort is maximized and their dignity is maximized. And so when I work on quality improvement processes that head in that direction too, I get a lot of fulfillment out of that. So I think yes, but yes, quality improvement does bring a lot of fulfillment, but it has to tap into that original meaning for the physician.
And what's something that they're interested in, right? And that often will come out of the conversation where you can see where physicians are laying a lot of emphasis or have a lot of concerns. So I think the one thing we talk a lot about is just going to physicians saying, how did things go for you? What are your questions? What are your concerns? what is your feedback? And by soliciting that feedback, we can kind of pick up on what's important to that physician, right? Because somebody who's concerned about the care of the family will probably address that. Somebody who's concerned about organ management will probably bring up some donor management things. And then we can start kind of honing in, oh, okay, I see that they seem to be very interested in that area. Maybe there's an opportunity here to, again, pull them into seeking their opinion and seeking their thoughts on how we can improve things. And that might then bring that sense of fulfillment.
And of course, Hedi, you know, as I'm listening to you and Dr. Lau speak, it's bleeding over into one of the other F's, right? It's that area of specific interest. So we talked about the feedback, the fulfillment, and what you're talking about is fit. These areas of interest is a fit with the physician. So that's one of the other F's. So we actually touched on 3 of the 5.
A little unintentional, but great.
Let's touch that in there, didn't we?
Yeah.
Well, as usual, I have learned more on this conversation again. So I really appreciate it. Thank you very much.
Thank you guys for having me.
Thank you, everybody, so much. Really appreciate your time. Take care.
Now, bye-bye.
Thank you.